Hi, everyone. This is Susan Clinton and my co-host Erica Melo. We are so happy to have been able to bring you several podcasts from our new feature called Tough to Treat. We've had several comments and lots of interesting conversation going around it. We would love to ask you to do the following. Please go to iTunes and leave comments and questions on the website right there. The other thing that we'd love for you to do is be able to rate us on iTunes. Every time we get 5s, it kind of moves us up on the mark. I know it sounds a bit brazen, but we're supposed to go for it. So we're asking you to please go to iTunes, give us a rating, and give us your comments. Thank you so much for the share.
This is Erica Mello along with my co-host Susan Clinton, and we are tough to treat. And in this podcast episode, we talk about a patient who had been experiencing chronic right knee pain. He is a junior golfer, and what was really interesting about him is that he experienced his knee pain in a specific point in his swing, more specifically the downswing. So we talk about the clinical reasoning process behind determining that ultimately the cause of his right knee pain was on the other side of his body. So we also talk about potential treatment options as well. So we hope you enjoy this, and thanks again for listening.
Hey everybody, it's Erica Mello and my co-host Susan Clinton here for, I think this is maybe our fourth podcast.
Our third patient.
Our third patient,
Yeah.
Exactly. So I hope everybody is enjoying it. And the name of the podcast, once again, is Tough to Treat. And we have a nice little subtitle below as well. So I hope everybody's enjoying it. I just got back from a course in Chicago, so I'm raring to go with talking about this particular patient. So should I just jump right in, Susan?
Yeah, I think let's just go ahead and make it happen.
Okay, so this patient I actually have discharged, but given the coursework that I did this week, and I thought he would be a good sample. So he was 12 at the time, and he basically had complaints of right knee pain, and he had been everywhere. Once again, typical story. Different physicians, different physical therapists, and he was a competitive golfer, a junior golfer, actually scratch golfer. I mean, really, really good. He had won tournaments with his knee pain and all, but I think literally the last tournament he played, which is one of the reasons why he came in to see me, he was trying to hit a ball out of the rough, and he just twisted his knee, and it was swollen, and he practically limped off the course. So he'd seen so many physios doing all knee strengthening, similar to your patient last week with the glute strengthening, and it just didn't get his knee better. It got his knee stronger, but he really had a lot of knee pain. And the monkey in the room was that he also was playing basketball. I saw him in the fall, and so that exacerbated, I think, an existing issue that he already had. And he basically told me that he had knee pain when he went into the downswing of the golf swing. And that's basically when you're, here I'm using my hands again, when you're in the backswing, and then when you're moving in, just when you contact the ball, that's sort of the downswing. You're taking the club down to hit the ball. And if you can imagine it, you need the weight shift. And if you don't weight shift, you're going to twist your knee. So with him, since he was 12 and his dad came with him to the evaluation, and I love golf, so I was really happy. I really got into it. And I didn't really feel a need to do any kind of special tests with him or any of that, because he probably had that done in the past, and he didn't really have knee pain any other time except with that specific downswing. And I mean, he could go up and downstairs fairly okay, maybe a little bit of soreness at the end of the day with downstairs, but not really crazy. He was a smart kid, a real smart, competitive kid, competitive golfer, and it says a lot for somebody in New York City, because he doesn't have access to a golf course every day like all the other kids have. And the first minute I met him, I noticed he was very sort of analytical, and he listened to every word I said. So I had to really make sure that I didn't put at such a young age all those beliefs in his system, because he kept saying, but my knee is strong, but it still hurts, and why is that? And And the father was looking at me. And I was like, and I
So
said,
see what I deal with every day.
right, and I said, well, and I actually just said outright, I said, well, that's great, but I don't think the knee is at this point the source of the problem. It's your pain sensitive spot, but it's not the real what's causing your issue. I said,
Mhm.
when you feel it the most is in the downswing. So let's look at the downswing. So, and the father's like, oh, no one ever did that before. I said, well, at the end of the day, you should it validates why he came in. If you have him sort of do a straight leg raise, do a squat, that's not going to show why he has problems in the downswing. So I sort of put him in the room, and every time he shifted his weight, actually he didn't even shift his weight, he twisted his knee and he had knee pain. And I look back at his history, he had, and no MRI or anything. He had, Osgood Schlatters, typical young
12-year-old growing male.
Exactly. And he was the doctor put him in a brace, and I was, and he said it didn't really help him. And so he took all that off. And what was interesting to note, though, is I just noticed when I looked back at it as well, is that he had a history of concussion. 3 to 4 concussions. He got hit by a golf ball.
Oh, how far? How long before?
Probably one that same year, and then 2 the year prior, and 1 before that.
Interesting.
Yeah. And I just said to myself, and I, looking back on it, it's like, you do a chart review and like, no wonder, and he had changes in his brain, and I think spatial issues. So yeah, and
balance issues, changes.
Yeah,
all of that.
Yeah. So
stuff.
Right. So I'm standing there, and exactly the balance. He couldn't put. Like I said, do you feel where your weight? He's like, no, it's pretty centered. I'm like, it's not centered. It is all the way over on his right leg, completely on the right leg. So I centered him, and then just said, let me just get you center. Close your eyes, and I centered him. And he's like, I'm way over to my left. I said, no, you're not. You're center. I let him go, and he went woof, all the way to the right. So his whole body schema, or his whole sense of spatial orientation on the right side was completely not, well, it was too existent. It was too much. I mean, he couldn't recognize his left, right?
Spending all of his time thinking about the right side.
The right side, right? And so I just had him do a body twist in standing, because you have to have full body rotation for golf. Of course, he had no problem twisting to the right, and when he went to the left, it was much harder. So anyway, I basically weight shifted him, and then I said, I'm going to sort of put your, just pretend you have a golf club in your hand and try to hit the ball. And when he did, I shifted his weight, and I actually couldn't. Like, he basically dropped the pelvis too much and then twisted the knees, what he did. So you have to have a little bit of a drop in the pelvis when you do that, but he was really dropping the pelvis. So I tried to sort of facilitate the best movement for him. I got him his weight over, and I couldn't move it any further. It was like this block. And I said, what do you feel when I shift your weight? He's like, I feel a tightness on my low back on my left side and my left hip, and his issue was his right knee. So I said, okay, that makes sense. If you can't shift the weight over because of some tightness or some, I want to use the word quirkiness, but some suboptimal brain strategy that you're using, you're not going to feel your limb. You're not going to feel your body. Like, you have poor kinesthesia on that side. So I said, okay. I facilitated the proper mechanics. I actually had a golf club in the office, and I said, just go through it. So I helped him shift the weight over. I really pushed him through it, and he swung the club, and he had no knee pain. And the father was like dumbfounded. And I was so happy, because this kid, he's a really good kid, like a really nice boy, and he'd been suffering for so long. And so those were the 2 basic things, believe it or not, I did in my evaluation. I mean, looked at the downswing, I checked his twist, looked at his center of mass, extremely hypermobile, very hypermobile. And, of course, he had his patella tendon was soft and, sore, and swollen. But, at the end of the day, when you keep doing what you're always doing, you're going to get the same thing, right? You're going to get a hot knee, right?
Or if the expectation is that my knee is going to be hot every time I do this, you can have that top down kind of effect into the tissues too.
Right.
And this has been going on with him for such a long time. And the interesting piece of it is that it still stays, even though for the length of time he was having this issue, it really was occurring during very specific activity.
Yep.
Wasn't occurring really any other time.
Nope.
He was able to kind of change patterns and move around it, except when he put a golf club in his hand.
Right.
And that required that certain movement that he had developed, and he couldn't get out of that certain movement, and so it just kept.
Yeah.
the circle, the pattern was so ingrained.
Yeah.
You couldn't even get him to move out of it, even when you tried to move him.
I know.
I find that fascinating when you can get into these different levels of sensitivity, because somebody else would have pain in their knee, even with stairs, with squatting, with crawling, and with golfing, everything. It'd be everything all the time. And he hurts all the time. It never is better. But here's somebody with some good sensitization, but really specific to an activity.
Yeah. And he was the type of that kid. He probably analyzed everything, and to his credit,
Mm-hmm.
But the concussion stuff, now that I look back on, I think that was highly relevant, right? His whole, spatial orientation. I'm no
Mm-hmm.
expert on treating concussion, but that definitely must have altered his sense of space and where he places his feet.
And when you think about golf and those kinds of things too, and gosh, getting hit in the head with a golf ball.
I know.
But anyway, but when you think about the requirements of golf, is the spatial orientation you bring up, the ability to know where you need to hit the ball to.
Mm-hmm.
Like if you're putting or if you're driving,
right.
You still have to, there's got to be that temporal spatial type of piece to it, so you can judge how hard and how fast and with what velocity and all of those kinds of things that you need to be able to do. And then the whole ocular cervico vestibular reflex system that could have been really affected, by you said you had more than one concussion.
Yeah, he had 3 and 4. It's a great point.
Was he treated for him?
Yeah, no, not formally. No, the father said no, they just resolved on their own. But as his kids started getting more competitive and playing a lot more tournaments, he was so good he could compensate so well for that issue for years until the knee just said no mas. I have to give it up here. So,
Mm-hmm.
and he's that good, and he compensated. But the fact that he was so flexible, he said, why don't maybe I need to stretch. I'm like, you don't need to stretch. You are super duper hypermobile. Your issue is the control and things like that. And exactly, he has no motor control at all. And interestingly, I just looking at the notes here, he did. On his left hip, his anterior hip capsule was a bit stiff, but other than that, I didn't really find anything sort of, significantly
Mm-hmm.
wrong from a joint perspective, and when I went to shift the weight over, I asked him what was he feeling in his body when I did that. I mean, I can see, but I wanted him to feel. He's like, I feel a tightness on my low back and my left hip, and I'm like, well, that makes sense. If you can't shift the weight over because of some tightness, because you're spending all your time on the right leg, the other part of the body is going to shorten to adapt,
Mm-hmm.
and trying to explain that to him and the father, it was like a light bulb moment, I think,
Mm-hmm.
for them. So that's what I did in terms of, the evaluation. I didn't really do any other tests or anything like that, because I basically got my answer. I had a treatment plan in mind, the minute I started watching him do the downswing, and I said to myself, well, this is what we need to do. I need to talk to your golf coach as well, because he's the one that sees you all the time. And before I sort of get into the treatment, I went over to it's here in New York. There's Chelsea Piers is a big sort of sports complex, and he takes golf lessons there. So
Mm-hmm.
they have really cool video equipment now. So they put him on the force plate with the pressure, and when he was swinging, 98% was the number of the entire swing was on his right leg. And that's kind of hard when you're trying to weight shift.
That's amazing, right? Wow. I find that fascinating. And again, I just want to take that back to the concussions too. As wonder how much of that had to contribute to, his maybe changing or stiffening or or postural control changes to to deal with what was happening in the brain and the head.
Yep.
That just set up that pattern that he felt safe there, and that's where he started working off of, because I don't think we choose to stand on one side or the other side. I think it just becomes something that our brain kind of figures out, okay, this is probably the best we're going to do, so let's make this one efficient, even though it may not be the most productive for something like golf.
Yep.
Which is
Exactly.
very, very, very interesting. So I'm just going to back up for a second before we leave the eval part, because I find it interesting that, one of the things that you said right off the bat was, I just decided to go right into his sports-specific problem.
Yep.
And you got that from the history, right?
Correct.
And
yeah.
Just so that the reader, the listeners can follow along, there wasn't any reason for you to feel like, oh gosh, he's 12 years old. I wonder if it's an ACL. I wonder if it's, like the typical Oscar Slaughter's. Is it a typical jumper's knee? Because you had mentioned basketball. I'm just kind of wondering if you might share just a little bit about your clinical reasoning as to why you went directly right into the to the sports-specific movement.
Right. Yeah, of course. He had been to many people before, and I think if an ACL was there, it certainly would have shown up. It wasn't behaving like, with an ACL, you're going to get more symptoms and more symptomatic activities, and he basically said, I can walk up and down the stairs. Okay, I can walk, no problem. I can walk on hills. I can go down hills. I can run. The guy can run. But he couldn't hit a golf ball. So that's one of the main reasons why I did that. No imaging was performed, but he was so specific about the issue, and he had been to so many other people, and he'd been to physical therapy before. They probably did all those tests, and not to say that's not something I wouldn't have done, but I didn't feel in my clinical reasoning that this kid, the reason why he came in, it didn't justify that type of an exam. It was very specific, and if I had felt that, for example, there was an issue with the ligaments or any kind of ligamentous laxity. He's hypermobile. I'm sure he's got loose ligaments. I don't think doing those tests would have added to the picture at all. And because I feel that he mentioned this one specific thing, that's why I did it. And it was more of a sometimes the intuition comes into play in my clinical reasoning, and I think that that's why I started there. If I didn't find anything there, I may have gone elsewhere, but it was pretty clear in that position. And then when I was able to take away the knee pain by just modifying a center of mass, that was pretty substantial. So that's why I did that. And go ahead, Susan.
Yeah, I was just going to bring that back to, I think that's the power of taking a great history and the challenge of having a 12-year-old and their father try to give you the history, but it sounds like, his that he really had analyzed his history quite a bit and came in ready to tell you everything that you needed to know, which is unusual in a 12-year-old.
Yes.
But
yes.
Really lovely when you can get it from someone. But I think that's the power of really listening to the full history. And really asking those questions, because if they're, it's the reason we ask, when does this bother you? What activities and what you're not doing or what's being limited because of what's going on can really begin to build the entire clinical picture, in a very meaningful way before you ever begin to take them into exam. And then when you took him straight to golf, or the movements for golf and weight shifting, and we're able to kind of begin to start working with that, I imagine the buy-in must have been incredible.
Exactly.
Because you were really listening to his story. You weren't superimposing what you wanted to do. You wanted to hear where it happened.
Yeah, exactly. I think that it was so meaningful for him. I think at this point, in his journey, if I had started doing all those other things, I probably would have lost him and not gotten that buy-in. And I think with these types of people, because you're their last resort, they're frustrated, you need to listen to them. And I probably spent over 45 minutes listening to a story. I do recall it was quite a long visit. So, that was helpful for me. And I established a trust with him, and, we just chatted about golf and just to sort of get that trusting relationship, especially with the child. We're big New York Mets fans, so that was quite good. We
common ground.
I know, so we bonded. So So when I did do those things, I think he got it, and in terms of it's meaningful for him and his and for his dad, because his dad
Mm-hmm.
is the one that takes him to all of the golf, and I think it validates why they came in. If he had walked out of the facility without me looking at a downswing, it would have invalidated the reason why he came in to see me.
Mm-hmm.
So I think, if you want it, you need to make it meaningful for the person. It's different for everybody, but that's the reason why I started with him. And I got a thorough history. And, I think we talked about this before. The patient basically tells you your whole treatment and evaluation in the
They
story.
certainly do if you take the time to listen and not
Yeah.
interrupt.
Mm-hmm. Exactly. So anyway, so I did go. I can talk about the treatment in a second, but I did go, and we'll just talk about the Chelsea Piers intervention again.
Mm-hmm.
So he gets on the force plates. He does this thing. They basically put a picture of him on a computer screen. These really cool graphics with Tiger Woods at this boy's age. They drew little lines and Tiger's even centered. You can see that my patient, he was way over. And when he saw that visually, I think something clicked in him kinesthetically, because we put him back out on the plate, had him, do the weight shift, and he was getting more onto his left side. So his brain was quickly trying to remedy the situation.
Right. Wanted to do, the video that shows the power of videotaping people in motion, and really
Yes.
able to let them begin to look at that themselves, because that's their own biofeedback.
Right.
He started realizing that I need to figure out how to do this differently.
Yep.
Because this is what I really look like.
Yep.
And so you start learning that what I feel may not always be what really is. And if I see myself doing this, then maybe I can begin to change it.
Right, exactly. And I think with him getting, after taking this course, watching himself, move, or watching him move, imagining these movements, it still activates part of the premotor cortex. So I think for him, getting, somebody other than his golf coach, because the golf coach said to me, I've been telling him he's been on his right leg for years, but he didn't get that buy-in because he obviously didn't have knee pain at that time, so it didn't matter to him, and he could compensate. And that's where physical therapists come in. We're the critical thinkers. We can figure it out, and that's why it's good to have that sort of relationship between a coach and a player, right?
Absolutely.
And
absolutely, and the besides the premotor cortex, you're also, working with the mirror neurons, and I think that's another piece. So when they can see themselves, they can be. I think all of us can be told 1,000 times, "You're standing on your left leg," but until something happens and you actually see yourself, then it registers, and then you start looking at your movements. There's a different kind of, I think, brain switch that clicks on. And we're talking about different pathways here.
Yep.
And I think that there's something very powerful about that. And the force plates told him some stuff, but it sounds like to me that it was the visual that really got his attention. That's from the central nervous system.
You're not kidding. It really got my attention. I was like, this is like really cool. But so he got that, and then they kept putting pictures of Tiger and him. And by, I would say, after half an hour, he got a lot of his weight onto his left leg, and he was swinging better, in the little room there. So when we got him back out on the practice range, I said to myself in my brain, how is he getting distance if he's all the way on his right leg? If he gets his weight shift over, can you imagine how far he's going to hit the ball? So down the line, I mean, he was getting the driver was over 250 yards, and he added another 25 yards to it with this change. I mean,
that fast.
I know. So that, I just wanted to mention that because it's so important to work with other, people who are working with the little athlete that I have, and just to show the power of the visual, right? And,
well, and meet them in the functional activity. You started the eval with the functional activity, but no way were you going to hit a golf ball in your clinic.
No.
And sometimes it takes meeting them in their functional, in their world. Meet them at their gym, meet them where the weights are that they're actually lifting.
Yep.
They're fatiguing, and they're telling you they're fatiguing. Maybe they need to go do their workout, and you meet them there to see
exactly.
But it happens, so that you can really help them begin to, so you can begin to figure out a little bit better with them what's what's going on. It's like meeting a dancer, on stage or in the studio. So you can see during class what's actually occurring. So you have that opportunity to move around and do that at times with people.
Yeah, and it's going that extra mile, because the dad came over to me and he's like, I can't believe that you came here. No one ever did that. And I said, well, they should have. I mean, I'll never forget it. It was a pouring, rainy Wednesday night in New York City. I'm shucking from 58th and Lex all the way to Chelsea Piers. But it was so worth it. And I think as physical therapists, I think going that extra mile for your patient, really, really helps. And that's how, we show our value to the family, and or even just suggesting certain things. And I think it's sometimes we don't realize the value of those little things. It may be just going shoe shopping with your patient or whatever. But that really helped him psychologically feel better already, because he knew that somebody had taken an interest in this. So I worked with the golf pro for a bit, and in terms of treatment, I'm not going to get into all of it. There's a couple of things I'll mention. I did do, since I'm a manual therapist, I did do some manual work on his left hip and his left low back. Not all the time, because he was super hypermobile. I gave him a couple. I give a child's pose out a lot, just to sort of open up the thorax, the rib cage. For him, I wanted him to do it just to open up the left side of his back. We did that for a couple of sessions. Just did some breath work, just to sort of reduce some of the tone in the muscle in the back. Mobilized his hip a little bit, just to reduce some of that tone in his psoas. Nothing, and I explained to him, I said, not because you have a stiff joint, you're actually quite flexible, but you have this, holding pattern of, of certain muscle groups. And the best way for me to intervene right now is through my hands and through different mobilization techniques. And I think he got that pretty okay. And then we started to move into the gym. And what I found, what was so helpful, I did everything right to left with him, everything right to left. I did a little bit of single leg work, but I really started facilitating that right to left motor pattern. I got him on a little teeter-totter balance board, had him go to the left, and see what would happen, just to sort of increase that representation in his brain of his left side. That's what I started to do at the beginning. And I did it via, ball throws against the wall, step, I didn't do squats or lunges or any of that, because that would have been not helpful in his situation.
Weight shift was what you were after.
Say again?
That's a weight shift was what you were after.
Exactly. And that was specific to his problem. And looking at the whole picture, the spatial representation in his brain, we had to get him off his right leg. And he was fun to work with. Had him throw against a rebounder, it was baseball season at that time. So we were just throwing to the left, and I was trying to make it fun, because at the end of the day, he is 12 years old. So we were doing, sports core down the track to the left only worked on the left side. Did, TheraBand to the left, rotational stuff with TheraBands, did everything to the left. And it's interesting, though, on this course this weekend, you took the course too, so correct me if I'm wrong. They talked about doing...
So the course was?
Graded motor imagery, which was fabulous, GMI. I took it in Chicago. It was wonderful. And they talked about using the opposite limb, which would be his left side, but to do both sides because of some form of activation in the motor cortex. I don't remember exactly. I have to go back and look at my notes. Do you remember anything from that?
So
it was right side, left hemisphere. So left side would work right hemisphere. That
right, right. And then they look at the motor patterns that go from right to left because of the desiccation within the brainstem area, and but they also look at the representation of the body. So if you look at the hand over here and you put the left hand where the right hand should be, then that begins to change the representation of what that left hand is, because it's now in the space where the right hand belongs. So they so that's where that left-right laterality stuff comes in as well, is being able to recognize, because if you're just staying in one spot and you're never crossing over and doing those other things, then you never get that that so you lose representation of one side versus the
Right.
other
Got it.
because it's only going one direction.
Got it.
Mm-hmm.
So that makes much more sense to me now. And when I was working with him, I just felt just do everything to the left, just do single leg, or step to the left. And I did different diagonals. Speaking of recognize, I did the recognize app on the knee with him, and his accuracy on his right side, which was where his knee pain was pretty low. I don't have the exact results here, but I wrote in my notes it wasn't great. So we did that every session. He did it at home. He probably wasn't as compliant.
So for the listeners out there, the Recognize app is a way it flashes pictures of left knees and right knees, and in different kinds of contexts and in different kinds of positions and from different angles and different backgrounds, with clothes, without clothes, with braces on, with socks on, with stretching, doing all kinds of different things. And the idea is, can you recognize as quickly one side versus the other? And so it sounds like to me that the side that he was having pain with was the one that he didn't have the best accuracy of recognizing compared to how quickly he could recognize the left side.
Correct. And the accuracy exactly was lower on the right, and the reaction time or the speed time with he had to recognize it was also lower. So we did that, and pretty much almost every time. And as I said, I don't think he was so compliant doing it on his own, to be honest, but he did do it, and I definitely think that was another eye opener, because he was kind of like visual. Oh, my right side, my right accuracy. He wanted to get them even. He was he's a competitive golfer. Are competitive in everything.
The competition kicked in. I have to do better than this.
I know. and then we did mirror box, and mirror box is another part of the graded motor imagery strategy or protocol, however you want to call it. And generally the mirror box is a small box with the mirror on one side, and the knee was not, it's hard to do the knee in that box. So I had we have a big mirror in our clinic, and it was near an open door, so I had him just sort of stand to the side so he would only see with his left leg out in front of the mirror, and I would have him and he would see the mirror image of his left in the mirror. So he was standing on his, he was standing, on his right leg, but he couldn't see it. It was in effect hidden, and he was doing things with his left. I had him do a little bit of a knee bend, a squat, just anything novel with the knee, full flexion, kicking, rotation, just anything we could think of to do with the knee. I don't know if you would have done anything differently in the mirror.
I did. I always find it challenging. You and I were talking about this before we actually got onto the podcast, when we were thinking about the whole body and how you could actually use a mirror, because we know that they can do it so easy with the box, with the feet and the hands. When it gets to the knee, it is a little bit more difficult, because even with the standing mirror, you're not really getting.
It's hard.
You don't really have the other side hidden as well as you would like to have it hidden.
Yep.
And but the things that I would do would be very much like what you would have done, just, standing, twisting, turning, tell them to turn your knee towards the mirror, turn your knee away from the mirror, so that they could kind of get that idea that, or maybe, I imagine you probably did some weight shifting. So he could kind of see that weight shifting occurring. We were talking also about, I think they had mentioned in your course to use a mirror and then have the mirror behind, so that you could see your back, or, and so I would think probably that'd be pretty interesting for the back of the knee, the hip, and the back.
Yeah.
But what would be really cool to see is if you could use your cell phone, how people will take their cell phone and turn it on rotate and take a picture of yourself taking a picture. So you get that image onto your cell phone and be able to look at, maybe the one knee, while the other one's moving to see, to see. I don't know. I find the whole thing very fascinating, but I think it's just a matter of getting creative.
Yeah, I know for sure. And, looking back on it, I think, we did the mirror for a bit, I don't know, 5 minutes, things like that every session. But as he got better, he wanted to do more of the work in the gym. He's a kid, he's
Mm-hmm.
12. And so I was really trying to make up things in the gym to try to get him on his left leg. I had him stand on a treadmill sideways and use his left leg to push the treadmill, like really slowly so he could use his left side, just making it up. And he had fun with that,
Mm-hmm.
And then I had him do, what else did I have him do? Just other weight shifts with bands, and he doesn't need to be lifting kettlebells, this kid. It's not a work. I mean, you need more finesse and rotation. So your imagination is your limit, and he really tested my imagination, I have to say.
To keep a 12-year-old interested and up board and active and continuing to do that weight shift.
For like a full hour. I treated him for an hour, so it was, sometime in the room we did, and then we went to the gym, and then after a while he's like, can I do a vertical jump, a box jump? And I'm like, you don't need to do a vertical jump, but I want to do a vertical jump. And I said to myself, if he could do a vertical jump and a box jump and he's good, then he's good to go. In the sense of his psychological, because he was always afraid to do those things. And his father was saying, well, you don't need them for golf, and you don't. But I think for him, he needed to see that he could do it and that he would be okay.
It was important to him.
Yes.
And whether he needed it for golf or not, he's still a 12-year-old.
Yeah.
He still needs to jump over the fence with his friends. He still needs the Dukes of Hazzard jump into your car kind of thing. I mean, he's a young man. He wants to some of those things. So I love the fact that it was important to him.
It was, and
and he vocalized it to you. I want to do it.
You have no idea what else he vocalized to me. He wanted to do those. He wanted to do the vertical jump where you reach up, like how in the NBA they measure like your span of how high you can jump. He wanted to do that as well, and so we had in the gym something like that. So I had him do, box jumps, and he did. And I was like losing it. I'm like, oh my God, please, he better not buckle his knee,
That's where you have to bury your own fears, right?
I know,
so that they don't get transferred to them. Like,
totally.
Maybe overprotective PT.
I know, because he was doing so well. I didn't want him to go back into that I can't do mentality, right? And so he did, and he was fine. He did a vertical jump, and he was fine. But I think if you restrict patients like that, especially kids, they just fall. I think we would have fallen back and, I can't do a vertical jump. And then the whole thing, I would have lost a bit with him, and mentality wise. And his kids they're so plastic, and their brains change so quickly that I didn't want him to go back and say, no, I can't do this. And now he's back on his right leg. You know what I mean?
And start carrying that label around, that he brought into the door with you the first time. Like you said, he had been and heard so many stories and had so many different things, and not only was he anxious and wanting it to change, but there's the whole parent element that's part of that as well, which is always difficult to navigate, because they can't help but be overprotective,
right,
and over manipulative.
Yep.
When it comes to like finding the right care for their kids, sometimes the harder they work, the worse it is.
Yep.
And that's
true.
So you walk a line of when is it okay to kind of push and say go for it, and when is it okay to kind of scale them back a little bit. If it had been somebody I think that you were truly worried about, you probably would have said, or I'm not going to put words in your mouth, but if you'd really been truly worried that he couldn't do the box jump, or he might have missed what was going to be kind of your go-to thing for him, or how are you going to kind of scale that for him?
You're asking me a question?
Oh, okay. Yeah. I didn't want to answer for you.
Oh, no. I knew it. I had a gut feeling he would have been able. He was able to do it. It's not like we did lunges or squats in the gym, but I knew this kid was running all over the place at school. I knew it. Running a class, going up and down stairs, and I saw a change in him when he started to get consistently pain-free, and was able to do all these things. And he was actually he went back and played some golf tournaments. After I first saw him, he didn't play for about 2 or 3 weeks a month because the knee was so flared. And
Mm-hmm.
it was a decision freely made by the parents, okay? And he was up for that. So I knew that it was going to calm down eventually, in terms of his, symptomatically in terms of his knee pain, but it wouldn't have stayed that way without the intervention. So, and that he had showed that in the past. He'd taken time off and he went back and didn't get better. So I said to him, I said, you can take some time off. He's like, I would like to. And I'm like, fine. And he did. But in terms of getting him to the box jumps, I knew he would have been okay. I would never have had him go up there and do that if I felt there was any inkling of the fact that his leg was going to buckle. Because I'd been doing a lot. This has happened toward the end. I had been doing a lot of, single, left-sided, shuffles, karaoke, all the way down the track, all left, and not once. And I did some agility work, left, all left, and then I mixed it up. And I knew that whenever he had to stop on a dime on both sides, like I'll do this thing where I have them run down the track and I'll say stop, and they have to stop and really stick it. And then I did it to both sides actually towards the end, and because I wanted to see how strong the knee was when he wasn't anticipating he had to stop, and that's why I did that. And he was able to do the box jumps fine. And there are many times where I have patients that want to do things. I'm like, I don't put them on because I don't think they could do it. But I don't tell them that. I just say, we're going to do that in a little bit, But with him, there was no question.
Yeah, I think it gets into the idea of the rehab program that you gave him included a lot of going in the direction that he needed to go because he was really good at going the other way. Why reinforce that? You needed to reinforce something that he didn't have, a new pattern, but you introduced it with a lot of variance. And I think that's the key. Is I think it's not just one or two magic exercises that everybody's looking for, but you gave him a lot of variance, and so that's going to carry over in golf because although they do the same thing over and over again, it's never the same. First of all, we know that, but they're always on different terrain, facing different things under different conditions and circumstances. And, different courses have different, obstacles and pieces to them as well. But I love the idea of the variance in which you did it and the ways that you did it, because then that allows him to be able to explore other things that he wanted to explore. And because you had taken him through such great variance and doing all those different kinds of things, you knew he had the ability to just jump up onto something. You knew it. Whereas somebody else that maybe that didn't have the ability to jump up and really wanted to do a 20-inch box jump, my thing in the clinic is, okay, let's work up to that. Do it here on this one. And if they're struggling, say, let's get this one a bit better before we start going up. So it's not like, no, you can't do it. It's let's do it different.
Yeah, and it's interesting. You mentioned the variance. Changing the context of all of these things is so important for everybody. Because their brains get used to this certain motor pattern, this certain activity. If you do the same thing, but a different way, it just adds to that whole malleability, of choosing a new strategy. And I knew that because he could adapt very well to what I gave him, and I varied the context up. I had him throwing balls down the court, chatting with me and doing things. And so I added all these variables in. I knew he would be able to adapt and pull from another motor strategy in his brain when he did the box jump, because he was that good, So that sort of sums up the treatment. We did, it was over a period of time, and then he actually went back to golf, and he came in like second, and he'd just drive, the distance just increased dramatically. And I'm just looking at his chart, I'm seeing all these pictures of him from the Chelsea Piers analysis, and he continues to do well. I see him often, in the gym, and who comes into the gym next door and works out sometimes. And I kept in contact with his mom and dad, and he and the golf instructor was really thrilled. And, just talking to the mom about him, and she said, you really took him in as a whole person, and I thought that was very telling.
That's amazing. That's the stuff we want to do.
Right.
We want to treat the whole person, and that's a beautiful example from beginning to end, finding out their story, listening to what's super important to them, listening to where their issues are, really listening to where their issues are. And then from the moment you started working with him, which was actually when you sat down with him, but the moment you started doing something physical with him, it was something that really super mattered to him.
Mm-hmm.
And we don't always have to start with range of motion and ligament testing.
Mm-hmm.
You don't
No.
always have to start there. I think
No.
sometimes one of the best places to start is a functional movement. And yes, it
Yep.
could have been a squat, it could have been a jump up, but that wasn't in the context of what he told you.
No.
You did, you chose a functional movement that had so much meaning to him.
Yep.
And immediately you started continuing your evaluation with that. Well, what if we did it this way? How about it this way? What happens if you come over here? Can you even come over here?
Mm-hmm.
You're not weight shifting, can you?
Mm-hmm.
and working through that, and then taking that next step into, well, let's go see what what the technology tells us.
Right.
And add that piece in so that we know. And so he's got that buy-in, like, okay, there's numbers that say I'm not standing on this leg. There's pictures that are telling me. She saw it the first time I did it. Now I'm ready to buy into the, like, let's do everything to the left, to the left, to the left.
Mm-hmm.
And then, at the end, giving him, back the things that were important to him. Maybe we'll see him on the juniors soon.
Yeah, he's it's funny. I was online trying to follow him, and he's playing with top golfers down
that's
in
awesome.
Florida, and I think at the end of the day, I had a lot of fun, and I said, this is why I'm a physiotherapist. Work with people like this, and to really enjoy myself. And I really had a lot of fun working with him. And I think a lot of PTs, we kind of go through. At the beginning of our careers, we're wondering where we're going and what our strengths are, and that's my strength and your strength. We just love to see these difficult patients and to figure it out, and it's meaningful for them, but it's also meaningful for us.
It is. It's a win-win.
Yeah.
And it's one that to be on people's journeys with them like that is such a privilege.
Yeah.
Maybe, at some point down the road, this young man will, when he's finished his golf career, will be a physical therapist,
right?
Working down there and remembering, that wonderful physical therapist, Erica, that we listened to his story. That was the turning point in his life when the chips were down for him.
Yeah. And I think, and just to add one more quick thing is that I think, and you mentioned before, just jumping into the functional. I mean, with people like that, you want to get the buy-in, and buy-in is different for everybody, but they need to understand why you did what you did, and I think with him, being that he is an athlete, he got it very quickly. With other people, you have to go through a whole lengthy explain pain conversation. I didn't have to do a whole lengthy one for him because I was able to make that correction very quickly, but I did do it. I definitely did it.
Yeah.
And
you already said that he was analytical and he was already trying to figure things out. And you met him where he was.
Yeah.
You didn't spend a whole lot of time talking about stuff that he had absolutely no interest in. You met him exactly where he was. And that was the perfect place to start. And I think we just have to kind of always take a step back and remember that it's not about us and what we want to get done. That's always the thing I tell myself. It's about you, Susan. This is about the person in front of you. And this isn't about how smart you think you are, Susan. It's about what it is they need at that moment.
Right.
And I think that there's so much wisdom in our clients in front of us that it just becomes so much fun when you really can tap into their inner wisdom. And he was full of it. It sounds like. I mean, he had his wisdom and he had his thing, and he was ready to, once you met him where he was and what was important for him, you had both him and his parent.
Yeah.
Exactly. Which was also a key when you're dealing with kids, is that you got to get everybody on the same team.
Right. Right. And I think that the father said, and I would also echo this, is the quality that you value most in somebody is their ability to listen and listen to you and listen to the story. And if anybody gets anything out of our podcasts, or is just listen.
Yes, I would totally agree.
Yeah,
totally agree.
Well, I think that's it.
I think that's it. This was
yeah.
another great case to talk about. We were able to bring in a little bit of graded motor imagery and
Yeah.
specific movement with sports-specific types of things today.
Yeah.
And so thanks for sharing your client with us. And if there's nothing else to add, I think we decided our take-home message today was listen and meet them where they are.
Yep.
Don't be afraid to start with functional movement as your exam rather than all of the other pieces.
Mm-hmm.
Much information you can gain to it. You can always go back to those other pieces and add them in as you move forward with your clients.
Yep.
So this is Susan Clinton and Erica Melo, and this is Tough to Treat. Thanks for listening.
Bye, guys.